Hi, I'm Doug Dormer. This is the Business of Health Informatics, B641, in the Department of Biomedical Engineering and Informatics at Indiana University in Indianapolis. This is Module 4, and this is Lesson 1. In this module, I want to talk about the government shutdown, and I want to focus on how to find a solution to a health informatics, health information technology problem, and a few other things along the way. Let's look at today's agenda. First, we'll do this lesson. We'll focus on in the news, talking about the federal government shutdown and the effect on health IT, or at least looking at healthcare through the lens of health IT. Then we will talk about, in lesson 2, we'll talk about telehealth and disproportionate share hospitals, a particular area of interest in this shutdown window. After that, in lesson 3, I want to talk about how to find a solution. What do we mean by a solution when it comes to health information technology? And we'll start with some work that our colleagues have published about their ability to predict, possibly, people who are at risk for suicide. Then I want to talk to you about how to develop a solution statement for my students for their own projects for this semester. After that, we have some work to do to prepare for a guest speaker, a wonderful guest speaker that we will have in the next week or so. And finally, I want to introduce to you the assignment 2, focusing on how to build and develop the need problem statement for your particular project for our class. I want to begin with a few thoughts that will set the stage for the rest of this module and really beyond looking at our course, I think. First, I want to offer a broad comment about what we mean by the business of health informatics, health information technology. At core, the business of HIT is about understanding why people do what they do, as well as what the consequences are of what they do with respect to health information technology. And I would say this applies also to healthcare more broadly, but we'll focus on health information technology and health informatics. It's not enough to say that if I can improve health outcomes, for example, or population health, or make the jobs easier, that necessarily is enough to cause people to adopt a particular technology solution. There has to be a business component to it. There has to be a who's going to pay for it question, and what's the value to them. That is what we explore when we talk about the business of health IT, the financial motivations that accompany improved outcomes and improved experience of healthcare. Second, I want to say this is not about politics. So today we have no choice but to talk about what's going on in the political arena. I'm not here to espouse any particular political view. What I am here to do is to talk about the consequences of the debate and of the decisions that are made. Now, it would be difficult to say things directly affect health information technology or health informatics. Health information technology, health informatics are affected indirectly by what happens in the world of healthcare policy, really in the world of policy much more broadly. So let's instead say that what we're doing is looking at the effect of policy decisions, the government shutdown, the debates that we see on healthcare, but we're viewing them through the lens of health information technology. While I'll make a number of assertions, I'm going to try to keep those assertions tied pretty closely to the facts. And more often, I'm going to try to raise questions, and I encourage you to do that as well, to explore the questions you raise, try to answer your questions, but think more in terms of questions that things raise rather than jumping to conclusions that are often difficult to see. I want to talk briefly, before we get into this too much, about the difference between a budget bill and an appropriation bill. Back in July, the federal government passed a One Big Beautiful Budget Act bill, OBBBA bill. That really presented a 10-year budget for the country. And what that really sets are limits on that each department, each agency can spend. It doesn't allocate the funds so you can actually spend it. It doesn't say how you will spend it. It just says here is the maximum amount and the priorities perhaps that we want to have. That is distinct from an appropriation budget. So where the budget bill might focus on 1 year, 3 years, 5 years, even 10 years, the appropriation bill focuses on the next fiscal year. That means that the appropriation bill is really a separate but critical debate along with the budget bill, and in many ways is more important to the direct activities that we as providers, that we as technicians supporting providers will have to be concerned about. So today's discussion will focus primarily on the appropriations bill, which is being debated, which is the reason for the government shutdown, with a secondary but significant focus on the constraints or changes in the one big beautiful budget bill. I want to comment on how common a government shutdown is in the United States. It's frankly pretty common. Hasn't always been so, but in the last, I think it's 50 years, there have been quite a consistent pattern. There's been quite a consistent pattern of government shutdowns, or at least games of chicken over who's going to cave when it comes to renewing the budget. The last major shutdown was in 2019, also under President Trump administration number 1, when I believe it was 35 days from the end of December to the end of January that the government was shut down. Ultimately, that shutdown was ended because of pressure from the air traffic controllers in the flight system. Air traffic controllers were not getting paid. They were told to do their jobs, but not getting paid, and so they started calling in sick. And that pressure, which disrupted airline traffic and really the commerce of the country, is what caused the parties to come together. I don't know how this one will end, but it has. But from what we see with the fact that Republicans have left Congress, at least for now, left Washington, at least for now, we don't see either side acting very open to finding a middle ground with the other. Question, therefore, is how long will this strike last? Next, I want to, as we prepare to look at this in more detail, I want to distinguish short-term consequences from long-term consequences. Short-term things are people being furloughed, but they'll come back, they'll get their back pay. People working, but they'll get paid when they're done. Furloughed means you're laid off, don't come to work, but we're still going to pay you when this thing is over with. Others are required to work, but aren't getting paid right now, a second form of it. And so that's distinct, because once the budget dispute is resolved and the government shutdown is ended, then we kind of go back to normal, and it was a challenge for a short period of time. That's the general characteristic. But there are also long-term characteristics which, whether directly related to the government shutdown or consistent with it, and you'll see what I mean by that in a minute, the long-term consequences are permanent changes with respect to, in our case, healthcare. Within the kinds of changes that we see and the consequences are the forms of spending are classified as either mandatory spending or discretionary spending. Mandatory spending is from things like defense, certain things like Social Security and Medicare are considered to be mandatory expenditures. Those funds are specifically allocated, therefore they are not part of the other part of this, discretionary. It's not a decision to say maybe we want to not fund it this year. These are commitments that have been made, and therefore they become mandatory payment expenditures. Within discretionary, those things that Congress can decide, or maybe the administration can decide we're not going to pay, we need to think in terms of two group types. One is critical spending priorities, and the other is optional spending priorities. So we'll go through some examples of that directly affect healthcare when we get to that part of this first lesson. While the overall approval process is tied up in Congress, the classification of what's a critical spending expense versus what's an optional spending expense, that's a question left to the executive branch, meaning to the administration, in this case of President Donald Trump. So we'll see some interesting consequences of what they consider to be critical versus what they consider to be optional with respect to healthcare and healthcare IT. We'll look at the effect on particular agencies from the NIH, the Centers for Disease Control, the FDA, and the Substance Abuse and Mental Health Services Administration. Now, the pattern is fairly consistent, and while there are significant differences between each of these, we don't have time to go through each one of them. I'm going to focus on SAMHSA, the Substance Abuse and Mental Health Services Administration, but I think you'll get the idea and know how to look at each of the other agencies. Let's in fact start with SAMHSA. Here is from their website, which you can see down on the bottom. Here is their summary of activities that will continue. SAMHSA will continue substance use and mental health programs vital to the safety and protection of Americans. A good general phrase, I'm not sure what it means. Going to the next paragraph, will continue previously funded operations and utilize available balances to provide important resources for those seeking help for behavioral health through Treatment Services Locator Program, Treatment Referral Line, and Suicide and Crisis Line. It strikes me about those two things in particular that the one is a locator service, the other is a referral service. The one which provides direct service is the Suicide and Crisis Line. When we look at things that last line is significant, most SAMHSA grants awarded in the prior year will have funds that remain available. So it means if SAMHSA has given you as a provider, as an agency, as a clinic, money, you can continue to spend that money. What will not continue? A shutdown lasting less than a month will have limited effect because, frankly, the argument is you can go 30 days, and if you're delayed with 30 days or less, well, that's not the end of things. You can weather that. That's the expectation. For new grantees, because many grants start on October 1st, the government's fiscal year ends September 30th. So what we're really talking about is what happens to those organizations that have new money in the new year. That shutdown could leave them without support for carrying out the activities of their program during even that first 30 days. Also, it notes that because of the delays and the layoff of the furloughs of staff, and we'll talk about that in a second, it would also adversely impact potential 2026 grants through the agency as new notice of funding opportunities, that's the NOFOs down here, would be delayed, reducing the turnaround for potential grant applicants, and I think having even a greater effect, perhaps having fewer grants, and we'll come back to what the overall implication of that is a bit later. I want to finally spend a moment with respect to SAMHSA on staffing. They plan to reduce the staff of SAMHSA during the shutdown to a total of 98 people. That's 13%. So 87% of SAMHSA is being laid off. Now, it's unclear whether people will ultimately get paid when they are furloughed. That's been the traditional pattern. There's been some talk that this year that no, if you're not working, we're not going to pay you for the days you didn't work. Of these 98 people, 5 are exempt staff. So they are exempt from being furloughed because of their activities or position are already funded or otherwise exempt. And 93 are accepted. The activities are deemed necessary by implication, not quite sure what that means, or for the safety of human life. That's part of that discretionary piece. I would say 5 look like they are mandatory because they're already funded. 93 are clearly discretionary and therefore are accepted from being furloughed. 33 of the 93 accepted staff are retained for the orderly phase down and suspension of operations to shut things down. 2 staff involved in safety of human life, 3 staff involved in activities to protect property, and 1 staff involved in maintaining computer data, and 54 Public Health Service Commissioned Officer Corps. 1 staff member at SAMHSA is left during the government shutdown, I take it, to manage all HIT, health informatics kinds of questions. And that's primarily a sustaining kind of a role. That's pretty significant to me, both in the definition of what's an accepted or a discretionary expenditure and what is then a mandatory expenditure. As we look at the 5 who are exempt and the remaining 93 who are accepted, a discretionary choice by the administration, including only 1 person who focuses on HIT. Which healthcare policies and funding are immediately affected by the shutdown? Well, examples of expiring health policies. Now, what does that mean, expiring health policies? As we've talked in past lessons, a number of programs, like the telehealth programs, operate the way they do on behalf of the federal government, which means Medicare in particular, because of waivers to the previous rules that were granted in 2020 during the COVID crisis. Those waivers expire at various dates, were set to expire last year in 2024. That was extended till March. In March, with a continuing resolution, that date was extended till September 30th. Now, without a continuing resolution, without any budget agreement at all, those permissions for telehealth have expired. So the issue isn't the government shutdown per se, it's the concurrent expiration of certain health policies. So here they are. Certainly, Medicare telehealth flexibilities, Medicare hospital at home program, a significant piece of using technology to extend patient care into the home. Section 330 community health centers, those are federally qualified health centers. Rural hospital designations of Medicare dependent and low volume. Medicare rural ground ambulance add-on payments. Delay of Medicaid disproportionate care hospital payment cuts. National Health Service Corps and teaching health center funds. Now, of these, I want to drill in Lesson 2, particularly into the Medicare telehealth flexibilities and the disproportionate, what it calls here, disproportionate care hospitals, what really should be disproportionate share hospitals. However, the exact impact of expiring policies is murky and will be impacted by the length of the shutdown and whether or not they are included in the 2026 funding package or whether they're included in a continuing resolution. Various flexibilities in place since the pandemic now revert to pre-COVID levels. This is that similar idea related to telehealth. Geographic restrictions reinstated, which means only patients in qualifying rural areas are eligible for Medicare. Home is no longer an allowable location to originate your telehealth call for Medicare. You have to go to a physician's office. And patients need to go on an allowable medical patients need to go to an allowable medical facility for telehealth services. FQHCs and rural health centers no longer qualify as a distance site and can't receive reimbursements for most telehealth services. Audio-only visits no longer qualify. And the expanded list of telehealth providers who can be covered by it, that list is now, expanded list is now expired, and we're back to a smaller list that we had before. These are huge changes that affect telehealth broadly. A comment on the hospital care at home project. Hospitals treating patients under the Medicare's AHCAH waiver will be impacted. All hospitals with active acute hospital care at home waivers must either be discharged, meaning they're no longer covered in that at all, or they have to be returned to the hospital to be inpatients. A major step away from the trends we've seen over the last 10 years towards keeping patients in their home and empowering them to manage their care in their home setting. Now, as you know, I like using generative AI, particularly to summarize certain things. I think it's just fine to use that. So I'll give you, as I require of you, my students, I'm going to give you the prompts that I use. So I asked from generative AI, what do Democrats want to end the government shutdown? And note, while they gave me, I think, 6 items, I only took the top 3 that related specifically to healthcare, which are extension of the Affordable Care Act premium tax credits. That word credits is a bit tricky. What it really means is that the federal government agreed to fund the cost of insurance, in part, for people who purchase their insurance through the Affordable Care Act marketplace. Second, they're trying to reverse big cuts to Medicaid, where the federal government gives money to the states match it in some measure, and that provides funding for people who are a vulnerable population served by Medicaid. And a third item, protection from health care cost increases, namely insurance instability, trying to use the federal government to balance the market, to control the market, to get the greatest reduction in uninsured people in the country. Those are the three health-related demands from the Democrats. So then I went through this little process. I wrote, summarize the effect of the big, beautiful budget on Medicare, Medicaid, and SNAP. So if the question I just asked was about what do the Democrats want to end the current government shutdown, this is a different question looking at the budget. That last piece looked at the appropriation that's not passed. This looks at the big, beautiful budget that it was passed in July. And so I said, summarize the effect of the big, beautiful budget on Medicare, Medicaid, and SNAP. Now, SNAP is arguably not a health care program per se. It is the Supplemental Nutrition Assistance Program, essentially making sure that people have enough food. Now, I would argue that as we look more broadly at social determinants of health, as we look at the way healthcare and healthcare IT have evolved, there's been at least a tendency, a desire to include things like food and housing, employment, safety in the healthcare equation. So I included SNAP just to see what the results would be and the effect on SNAP, even though it's not quite traditionally thought of as part of healthcare. After AI gave me a pretty good summary of that, its generative AI said, if you want, I can produce a one-page fact sheet with the exact bill sections, by citation, that change each program, or build a short table comparing the current law with the likely impact of each program. Which would you like? I said, build a short table and include the dollar amount or number of people affected. So here's what we have. Looking at the three programs, Medicaid, CHIP, the Children's Health Insurance Program, SNAP, food assistance, and Medicare. I'm not going to read all these in detail to you. You can pause and study them, but it's significant. Under the budget bill, stricter eligibility requirements, more frequent redeterminations, requalifying, work requirements, caps on the amount, shifts in federal-state burden. Cuts expect $863 billion over 10 years to Medicaid. I want to focus just a moment on this $863 billion. We get tangled up in the numbers. $863 billion in the federal part of it is the reduction over 10 years. Later, we'll see the proposed reduction in the appropriation applicable to the next year. It could, therefore, by putting this limit of reducing that amount of money, remove 10.5 million people from Medicaid. Now, those numbers vary. As I've said before, you can look at the source and get slightly different numbers. The Congressional Budget Office says maybe 7.8 million additional uninsured. It also says 5.2 million will lose Medicaid under harsh work requirements. So whether it's 14 million or 10 million, a lot of people may lose health insurance, undoing a lot of the work that was done under primarily Democratic administrations over the last 10 years. With respect to SNAP, the food program, cuts of $295 billion over 10 years, and another estimate was only about 186. So what they'll do is set a high number for the department, and in this case, SNAP comes under the Department of Agriculture, not the Department of Health and Human Services. So within that, how we might choose to narrow that across the multiple appropriations bills, that's where you get a difference between some estimating $295 billion for SNAP, others saying what's only $186 billion. Nonetheless, it's projected that more than 2 million people may lose access to SNAP benefits. Medicare, that's interesting. While some proponents claim Medicare benefits are untouched, watchdogs estimate Health program cuts in the bill will exceed $1 trillion. Those are a little bit indirect things like blocking certain rule implementations. There was a proposed rule that said you have to have certain minimum care staffing. And now they're saying we won't have to have that, which means fewer staff for the number of patients, which will affect not only the number of staff and the cost, but will also affect perhaps the number of people who can benefit from such care. What's the effect of the one big beautiful bill on Medicare insurance subsidies? Here are 3 or 4 points. Expiration of the Affordable Care Act premium tax credits. And I chose to put this whole thing on the screen because you can, and this again comes from a generative AI request, but notice that it gives me the sources that I can go back to. And again, we see our friends at Kaiser Family Foundation, KFF. We can also look at several others, the American Hospital Association, the Center for Children and Families. So I like this as an approach. I don't think it cheats. I think it allows us and empowers us to find the information and the answers we need effectively. Under higher premium costs, especially for low and modest income enrollees. So a 28-year-old with modest income might see a benchmark silver premium cost nearly double in some places. I've read that from the Kaiser Family Foundation that the average increase in health insurance premiums is expected to be 114%, more than doubling the cost of health insurance. And of course, that means that more healthy people who aren't required to have health insurance will say, nah, I can't afford to have it. And therefore, the mix will skew towards more people with illness, more people who need the services, and in turn exacerbate the pressure on what the market will say the price needs to be, all because the government is stepping out of its role as incentivizing people to buy insurance by providing subsidies. A greater number of uninsured is therefore a consequence. The indirect effects in Medicare dual eligibles. Dual eligibles means people who have Medicare, but also because they are in low income and Medicare doesn't cover every cost, have Medicaid as a dual eligible person to cover those costs not covered by Medicare. Reductions in subsidies or cuts to Medicaid could affect their coverage, coordination of benefits, and their out-of-pocket burden. And finally, Medicare itself officially is untouched, but with pressures and risks. The bottom line with respect to Medicare, the one big beautiful bill would effectively end the expanded insurance marketplace subsidies, leading to much higher premiums and out-of-pocket costs, especially for lower and modest income people. It would contribute to a large increase in the number of uninsured people, while the administration insists that Medicare benefits themselves are not cut by the bill. There's the political debate, along with, I think, reasonable expectations of the consequences. What's not on the table right now, and what I mean by this is, if the debate on the table, as we saw from the Democratic requests, in their debate over the appropriation bill, they want to undo some of the effects of the budget bill. I ask the question, what's not under debate right now? The National Institutes of Health is largely spared compared to what was in the one big beautiful bill. There are some targeted cuts to newer high-risk programs and programs seen as optional or policy-oriented or more vulnerable, which means if the work you are doing as a health IT practitioner is in support of one of these programs, that funding not only was cut in the budget, but is supported by the cuts in the current appropriation bill, which are not in the current discussion being challenged by the Democrats. They're not a condition. Addressing those are not part of the conditions of settling the budget debate, and therefore it's reasonable to expect that those changes will go forward in the current year. Major shifts in the FDA and regulatory oversight staffing. While core safety and regulatory functions may be delayed or constrained, the cuts in support roles are significant. So it's not just a cut in or delay, it's likely to be cuts in their function. Thinking of drug approval, thinking of software as a medical device approval process. They're saying permanent changes may be in priority as well as in cost availability for the staff to do those jobs. Strains on public health and mental health services, reductions in SAMHSA, CDC, local health department funding. And Senate pushback matters, here it notes. The Senate version of the HHS funding bill rejects many of the more extreme cuts. That's the Senate proposal, but I haven't heard it be a frontline topic as we see with insurance subsidies, for example, or the direct cuts to Medicaid. So there's some overlap there, but we can see, I think, that even if they settle this, many of the reductions in funding provided under the One Big Beautiful Bill will not be undone in any case, are not even being aggressively pursued in the resolution of the present shutdown and the present appropriation dispute. Thanks for watching this video. That's the first part about the government shutdown and the budget debate generally. Next up, I want to look more closely at telehealth and the disproportionate share hospitals issues.